Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of adult granulosa cell tumor, but with unusual growth pattern. So this is a case of a 43-year-old female patient who presented with abdominal pain and was found to have right ovarian mass. And as you can see here from the low power magnification, there is a dark staining area, a fibroblasts, and then another lighter staining area with some myxoidish background. I'm going to zoom in first into this area and then into this area. And this is the dark staining area. And as you can see, this is cellular, composed of proliferation of cells with round nucleus, with a small prominent nucleolus. There isn't much in the way of grooves. This is extremely important because remember, granulosa cell tumors, adult type, usually shows the grooves. Characteristically, the grooves are very important in establishing the diagnosis of adult type granulosa cell tumor. But in this case in particular, there weren't any, and there was a small prominent nucleolus. And this is another area or another focus from the dark staining area, the more solid proliferation, where we have the nuclei vesicular with a small prominent nucleolus, some scattered mitotic figures, not really much in the way of mitotic activity, and another focus where the cells started to become slightly apart from each other, and some cytoplasm, acidophilic cytoplasm, started to appear in the background, yet we have still the vesicular nucleus and the small prominent nucleolus. And then we're starting to move now into the area with the myxoidish background. And as you can see here, the cells started to have more acidophilic cytoplasm, like the one here, or the one here, or the one here. This is luteinization, and this is an occurrence or a phenomenon that can occur in a granulosa cell tumor. And when the cells are luteinized, they tend to lose their grooves. They have this small nucleolus, which is typical of luteinized adult granulosa cell tumor. And then moving again more towards the areas where we have the myxoid degeneration and some macrofollicle formation. There isn't any microfollicle formation. There isn't any called Exner bodies, which is again characteristic of the usual pattern of growth of a granulosa cell tumor. And as you can see here, again, more of the acidophilic cytoplasm of the tumor cells started to appear along with the vesicular nucleus and the small prominent nucleolus. And then again, moving more towards the myxoid areas, because part of the tumor was extensively myxoid. You can see here that the cells are actually pink in color. Why? Because of luteinization of the cytoplasm. And then coming here into the area which was extremely myxoid, and as you can see here, some of the tumor cells even were adherent to vessels, giving an impression of pseudopapillae formation. But definitely, in addition to the myxoidish background, we have this acidophilic cytoplasm. In a way, it was reminiscent of a rhabdoid tumor. This is because of luteinization. So remember, with luteinization, you have vesicular nucleus, you have prominent nucleolus, and you have some acidophilic cytoplasm. And then the granulosa cell tumor can show a variety of a growth pattern in addition to some scattered mitotic activity here and there. Look at the appearance here. If you don't think of a granulosa cell tumor, probably you will not order the appropriate immunohistochemistry to support your diagnosis. And look at here, look at the cell with the vesicular nucleus and the prominent nucleolus, scattered vacuoles, vacuolization in the background stroma, and more here. I tried really to give you a feeling of the area area of the myxoidish appearance of the tumor cells, in order just to have this at the back of your mind. Whenever you encounter a similar case, always think of a granulosa cell tumor. So these are the two areas that we had, the solid cellular area and the more myxoid area. And now into immunohistochemistry. Inhibin was positive in both areas. Remember that inhibin sometimes shows only this focal cytoplasmic positivity. It does not show the diffuse positivity in a granulosa cell tumor. What is really more useful is the nuclear staining with SF1, where both in the solid areas and in the myxoid areas, almost each and every cell was positive with SF1. Cytokeratin is extremely helpful, and it frequently shows this dot-like cytoplasmic staining. Again, don't be fooled, don't miss the diagnosis of a granulosa cell tumor, and this is the myxoid area showing less of a positivity with the cytokeratin. Now, EMA importantly should always be ordered, and it has to be negative, because adult granulosa cell tumors are typically negative with EMA while they are positive with cytokeratin. This is in contrast to carcinomas in general and to juvenile granulosa cell tumors where EMA is typically positive. PAX-A, I ordered PAX-A just to make sure that I'm not missing a carcinoma. Important differential diagnosis, especially the large cell variant of the small cell carcinoma. And SAL4, because sometimes germ cell tumors might have this unusual appearances. And remember, I shared with you once the unusual case of a yolk sac tumor in an adult individual. So always at the back of your mind, whenever you encounter unusual morphology for an ovarian tumor, regardless of the age, please order SAL4. Now, reticulin special stain is very helpful because it shows groups or nests of tumor cells surrounded by the reticulin fibers, in contrast, for example, to fibroma thecoma, where we have reticulin special stain file or reticulin fibers would be surrounding individual tumor cells. So the final diagnosis in this case is adult granulosa cell tumor, the stage, because the mass was received intact to the pathology and there were no other deposits or metastases anywhere else. The final diagnosis was PT1A, FIGO1A. Remember that you have to think almost always of a granulosa cell tumor, especially in perimenopausal females with ovarian masses, because this is the typical age for the presentation. Remember that granulosa cell tumor can have a variety of a growth pattern, and although the classical morphology and classical teaching is a tumor with the grooved nuclei and called Exner bodies, sometimes you don't find these findings, which are considered to be characteristic, especially if the tumor undergoes luteinization. Then those morphological clues will be lost completely. Remember to apply the appropriate immunohistochemistry. Cytokeratin can be positive in granulosa cell tumors, but typically EMA is negative. And almost always keep at the back of your mind the unusual presentation of germ cell tumors, for which you need only to apply SAL4 in order to support or negate this important differential diagnosis. I hope you find this tip useful in your daily practice. Thank you.